All right, so good afternoon, everyone. My name is Vanessa Rubeis, and I'm a PhD candidate in the HRM program working under the supervision of Dr. Laura Anderson. Today, we'll be talking about the association between adverse childhood experiences, adulthood obesity, and stress during the COVID-19 pandemic. The relationship between obesity and stress is complex, with cyclical and bidirectional associations across the life course. So this means that stress and obesity are constantly impacting each other. For instance, a major stressor in a person's life is adversity that occurs during childhood. Adverse childhood experiences, or ACEs for short, include a wide range of negative events that occur during childhood and adolescence, such as abuse or neglect. It has been found that ACEs influence the development of obesity later in life. If we think about the COVID-19 pandemic, this is a major stressful event that has impacted people across the globe. There has been limited research that has taken a comprehensive approach to explore both proximal and distal risk factors for stress experienced during the pandemic. If we think back to the cyclical association between stress and obesity, this helps to identify two potential factors that may play a role in differential experiences throughout the pandemic. These are ACEs and obesity. So that brings us to the objectives of the current study. We aim to evaluate the associations between both ACEs and obesity in measures of stress that occurred during the pandemic, and to examine if the association between obesity and stress is modified by ACEs. To address these objectives, we used a longitudinal study design using data from the Canadian Longitudinal Study on Aging, which is also known as the CLSA. There are two cohorts in the CLSA, the comprehensive and the tracking cohorts. The main difference is how data is collected from participants. So for instance, data for the tracking cohort is only collected by telephone, whereas comprehensive cohort participants had data which was collected by in-person interviews. The CLSA has collected data at baseline, which was from 2011 to 2015, at follow-up 1, which was from 2015 to 2018, and in April of 2020, the CLSA COVID-19 questionnaire study was launched to collect pandemic-related data. The CLSA COVID-19 study collected longitudinal data over 9 months. So both of the exposures for our current study were taken from follow-up 1, and the stress outcomes, which were measured at CLSA COVID-19 exit survey. So at follow-up 1, participants were asked to recall 8 adverse childhood experiences that occurred before the age of 18. These included things like parent divorce, abuse, death of a parent, exposure to intimate partner violence, neglect, and family mental health problems. We then created a total score where we summed the number of ACEs experienced. This ranged from 0 to 8. Since relatively few people reported 5 or more experiences, we collapsed 4 to 8 together. Assessment of obesity also took place at follow-up 1. People in the comprehensive cohort attended an in-site visit where a trained research assistant measured both height and weight. For tracking cohort participants, they self-reported their weight and height. People typically underreport their weight when using self-report, so to overcome biases associated with this, we applied a correction factor that was developed using data from the 2005 Canadian Community Health Survey. After applying this correction factor, we did in fact see that average weight was slightly underreported. We used height and weight to calculate BMI and applied standard cutoffs from the World Health Organization to define obesity, and more specifically, severe obesity class 1, 2, and 3. To measure stress in this study, we used stressors and the perceived consequences of the pandemic. In the literature, stress is often measured using objective and subjective measures or scales. However, the CLSA COVID-19 questionnaire did not include these direct measures, rather included measures that were adapted from previous research on natural and human-made disasters. The first outcome was a total stressor score. Participants were asked if they had experienced any of the 12 stressors since the start of the pandemic. These included things like if the participant was ill, if someone close to them was ill, or if they had lost their income. We then created a total score by summing the number of reported stressors, which ranged from 0 to 12. The next outcome was stressor domains. We created 4 distinct domains where we grouped similar stressors. The 4 domains were health, resources, relationships, and caregiving. Each of these domains were treated as separate count outcomes where the range of values varied. So for instance, for the health domain, there were 3 stressors within this domain, so the range was from 0 to 3, whereas the caregiving domain only had 2 stressors, so this score ranged from 0 to 2. Our last primary outcome was the perceived consequences of the pandemic. Participants were asked how they would describe the consequences of the pandemic on them and their household. Response options range from very negative to very positive. Since there were relatively few people who responded to the extreme options, we collapsed negative and very negative, and positive with very positive and neutral. As I previously mentioned, outcomes were measured at CLSA COVID-19 Exit Survey, which was collected from September to December 2020. However, both questions asked participants to reflect on their experiences from the beginning of the pandemic. So that brings us to the statistical analyses. For Objective 1, we ran separate models for the 2 exposures, which were ACEs and obesity, with each of the outcomes. We used Poisson, negative binomial, and logistic regression to estimate relative risks and 95% confidence intervals. We ran both unadjusted and adjusted models. For Objective 2, we wanted to determine if the association between obesity and stress was modified by ACEs. Prior to this analysis, we dichotomized the ACEs variable, so we had those who experienced 1 or more ACEs versus those who experienced 0. We assessed effect modification by ACEs on both the multiplicative and additive scales. To evaluate the multiplicative scale, we estimated the ratio of relative risks, which is also known as the RRR. To do this, we included an interaction term in the adjusted regression models for the joint effects of obesity and ACEs for all stress outcomes. To evaluate the additive scale, we calculated the relative excess risk due to interaction, which is also known as the RERI. To calculate the RERI, we use the formula that you can see on the slide. So for instance, to determine the RERI for obesity class 1, we used the joint effects relative risk where both ACEs and obesity were present, subtracted by the relative risk where obesity was present and ACEs was not, subtracted by the relative risk where obesity was not present and ACEs was, plus 1. We included 23,972 adults from the CLSA in this study. Most participants were aged 65 to 96 years, of white racial background, and over half had a household income between $50,000 to $150,000. 61% of people reported 1 or more ACEs, and about 31% of the sample had obesity. When looking at the stressors reported, more than half of the sample reported experiencing at least 1 stressor that fell within the relationships domain, and about 30% of people reported experiencing stressors that fell within the health and resources domains. We also can see that most of the sample reported that they had perceived the consequences of the pandemic as negative or very negative. So here we can see the results from Objective 1, where we evaluated the associations between ACEs and obesity with various measures of stress. I've removed the results for the perceived consequences of the pandemic for this presentation given the limited time. We found a dose-response association for ACEs in all stress outcomes. So as you can see on the slide, as the number of ACEs increases, the risk of reporting an additional stressor also increased for all domains, as well as the overall total number of stressors. So for instance, people who reported 4 to 8 ACEs relative to 0 ACEs were 53% more likely to report an additional stressor in the resources domain and 44% more likely to report a stressor in the caregiving domain. We saw somewhat similar results for the association between obesity and the total stressors and the health and resources domains, whereas obesity level increased, the risk of reporting an additional stressor also increased. We did not find consistent evidence of effect modification on either the additive or multiplicative scales by ACEs for the association between obesity and any of the outcomes. Only the multiplicative interaction between class 3 obesity and ACEs for stressors within the health domain was statistically significant. So because the RERI is less than 0 and the RRR is less than 1, this indicates that among people with class 3 obesity, those with ACEs compared to those with no ACEs were less likely to report an additional stressor within the health domain. So this study is one of the first to use a life course perspective when evaluating risk factors for stress experienced during the COVID-19 pandemic using a large national sample of Canadian adults. This study was limited by a primarily white sample, and the stressor data was collected early on in the pandemic, which may not reflect experiences through subsequent waves of pandemic. The findings from this study do confirm that stress and obesity do share a cyclical relationship, as we identified that obesity does influence how people experience the pandemic. Although we found limited evidence of effect modification on this association, it was apparent that using a life course perspective to evaluate risk factors for stress experienced during the pandemic was important. Future research will be needed to explore the long-term effects of stress that occurred during the pandemic on future health outcomes, including obesity. I would like to thank my supervisor, Dr. Laura Anderson, thesis committee members, Drs. Lauren Griffith and Jean-Eric Tarid, and content expert, Dr. Andrea Gonzalez. This research was made possible using data collected by the Canadian Longitudinal Study on Aging and was funded by the Federal Student Work Experience Program through the Public Health Agency of Canada. Thank you for listening to my presentation today, and I look forward to any questions that you have.